Okay, good. So, good afternoon, everyone. My name is Dr. Ijeoma Nadim Opara, and I will be serving as your host and moderator this afternoon. Welcome to today's learning activity, COVID-19 pandemic through a health equity lens. And it's brought to you by the Wayne State University Department of Internal Medicine, Social and Structural Determinants of Health and Health Equity Initiative, the Wayne State University School of Medicine, Office of Diversity and Inclusion, and the Global Health Alliance of Wayne State University. I am the founding director of the Social and Structural Determinants of Health and Health Equity Initiative. And our mission really is to co-create a more equitable and just world for all through educational innovations that bring together medical trainees, faculty, and the public. I am also the co-founding director of the Global Health Alliance under the Wayne State University Office of Global Affairs, which is a multidisciplinary collaborative community of practice in global health education, research, advocacy, and service. I am also the course director for the Global Health Concentration at Wayne State University School of Medicine, GLUE, and Associate Program Director of the Detroit Medical Center Internal Medicine Pediatrics Residency. And believe it or not, I'm also a wife and a mother of 3 amazing little girls, and that may or may not become apparent during the course of this conference. So again, I say welcome to you all, and I hope you are all enjoying peace of mind and good physical, mental, and spiritual health during a time such as this. Now, today is really an opportunity to have an intimate, honest, and open conversation around issues concerning inequities as it relates to the COVID-19 pandemic. How, although this pandemic affects and can affect everyone, it does not affect everyone equally. Those differences or disparities of impact that are driven by systemic inequities and result in the observations of the disproportionate impact on communities of color and other communities made vulnerable, including, as said, communities of color, particularly African American, as well as other populations that are made vulnerable vis-a-vis housing security, gender, incarceration, and mental health. Now, we recognize the intersectionality among these identities and statuses actually serve to compound the disparate effect of the pandemic accordingly. So this really becomes necessary to form a narrative around what really should be happening in terms of the equity lens as we contend with this pandemic. It is also a unique opportunity today to learn from diverse disciplines. This truly is an interdisciplinary meeting point of human and animal, biomedicine, environmental science, and social sciences, if you will. We acknowledge that there is an absence of a more robust environmental science perspective, but they will be mentioned by our One Health expert, Dr. Amuguni. Also, suffice it to say that COVID-19 is being studied for its impact on the environment, especially as carbon emissions with physical distance and staying at home has decreased, as well as how the SARS-CoV-2 virus potentially interacts with food and water sources. This perspective vis-a-vis the environmental or planetary perspective will be expanded upon in future series and webinars in this health equity series that we are beginning, and today being our part 1. And it will include perspectives concerning other populations made vulnerable, including Latinx, immigrant groups, LGBTQ plus communities, First Nation communities, and other indigenous groups, the disabled, etc. Those voices necessarily may not specifically be mentioned today, but again, there will be space created as we move forward. Today, we will also learn about international experiences and best practices from East African nations, particularly Kenya, Uganda, and Rwanda. And those lessons that are potentially translatable locally here in the US and Detroit. Now, before we proceed, a bit of housekeeping. The session is being recorded and will be made available through Wayne State University Department of Internal Medicine, Office of Diversity and Inclusion, and upon request, so you can email me. All participants are muted at this time, and there will be a question and answer period at the end, as well as brainstorming opportunities. I'll talk about that in a second. You are muted at this time. However, when it comes time for the question and answer piece, you are able to *6 on your phone or unmute, but use your unmute button on your device to speak when we get to the audience question and answer period. But for right now, we'll stay muted. The format of today's session is going to start first with a background and housing insecurity remarks by myself, just a very brief remarks. Then I will introduce our panelists. The panelists have some minutes to share their perspectives. Then I will have a conversation with them briefly, and then we will open up the floor to you all to ask your questions. Then the panelists will end with final words, and then we will have an optional brainstorming session at the end of the conversation. So from around 1:10 or so to 1:30, for people to share your thoughts around research, quality improvement, and advocacy solutions as it relates to health equity during COVID-19 pandemic. And so this is an optional special space created for those conversations. And you can also feel free to use that as a space to reflect on what you learned today and what you gained from the conversation that has occurred. And just another quick comment on terms of the Q&A. Even though there is a scheduled time for the Q&A later in the session, feel free to put in your questions in the Q&A feature of Zoom throughout the conversation. And I will be collating those and applying those and deploying, if I may say, to the panelists when that time comes, okay? I want to especially shout out any internal medicine and MedPeds residents that I have in the audience, and wanting to really encourage you to kindly complete your evaluations in new innovations for this session. It's always extremely useful and happy, and happy too, but extremely useful and for us as we continue in this format that we're learning as a result of pandemic and really evolving education online and virtual education experiences. So if you could kindly be so kind as to leave your evaluations and complete them in the new innovations. And for anyone else who would like to share feedback, please email me. I know we have a wide diversity of audience right now from various backgrounds. And so you email me and I'll share my email at the end and provide your feedback, and it will be so wonderful. Okay. So very quickly, we all know, I think we've heard ad nauseum about what's going on and the disparities on the national scale in terms of COVID-19 and how it's affecting disproportionately African-American citizens, whereby Black Americans are experiencing higher rates of mortality and higher rates of hospitalization, admissions to the ICU, etc. Indeed, overall poor health outcomes. This is a graphic from the Los Angeles Times in April 7th of this month. And as of this day, I'm sure there's even more up-to-date data. As you know, this is a rapidly evolving phenomena. Data is being produced every nanosecond, it seems like. And so I'm pretty sure by the time I refresh, I will get more updated data. But as you can see, in Louisiana, Michigan, Illinois, North Carolina, who are reporting racial data, we can see that we are number 2 in terms of the numbers of African Americans disproportionately killed by this disease. In Louisiana, they're experiencing 27 deaths per 100,000 of African Americans, and here in Michigan, 21.6 deaths per 100,000, right behind Louisiana. And again, those numbers are rapidly changing. We're seeing numbers produced out of Massachusetts and other areas of the country, as people are now reporting data, racial data, to show the disparities. This is another table from the Michigan Health Department, the Department of Health and Human Services. And as you can see here in Michigan, 40% of deaths are attributable to African Americans. And even though we constitute about 11 to 13% of the population, truly the disparities are stark. Indeed, COVID-19 is not the great equalizer it initially was referred as earlier in the course of this adventure, shall I say. It is indeed the great magnifier, truly amplifying the inequities that always existed in this great nation of ours. And we're going to talk about why, and that's the mysterious conversation. Why is this? And it's almost like we're suddenly clueless as to the reality of the nation. And today we will spell it out why African Americans are disproportionately dying from this disease. And it's not just high rates of cardiovascular disease, diabetes, hypertension, renal failure, because even then, why are they increased rates of hypertension, renal failure, diabetes, cardiovascular disease in African Americans? Why is that? And so answering those root causes and those root questions, and going to the nitty-gritty of what is producing the disparities that we observe is part of the conversation today, and our panelists will be helping shape that narrative. I want to very briefly just discuss housing in terms of when we talk about populations that are made vulnerable. And it is, clear that the link between housing and health. And in fact, housing is itself an intervention in disease process, really, if the individual or family is housing insecure or homeless. And so truly housing is a major social and structural determinant of health, and is played out strongly during the pandemic, indeed. And what we see is that homeless individuals and families are disparately impacted by the COVID-19 pandemic. In 2018, over 2,000 people were identified as chronically homeless in the city of Detroit, meaning that they've been diagnosed with a long-term disabling condition and have been homeless 4 or more times in the past 3 years in the city, or 1 year continuously with that disabling condition. And of course, when we talk about housing insecure individuals, we must also include those who are acutely homeless, living on the streets, in the cars, in shelters, but also couch surfing. And we know that homeless individuals and families exhibit high rates of disease, both mental and physical, and disability, reduced access to treatment, poorer prognosis than the general populations. And when you layer on top of that additional vulnerabilities such as food insecurity, violence, victimization, mental illness, substance use disorders, you only serve to amplify the burden of disease in this population, leading to a cumulative disadvantage optimally that then renders them susceptible to communicable and non-communicable disease and pathologies. In shelters, the close proximity and harsh elements of the outdoors, malnutrition, compromised immune systems, poor access to clean water and sanitation, comorbid disease burdens, all this truly, again, places those that are housing insecure at high risk of not only contracting the novel coronavirus, but transmitting it to others. People experiencing homelessness also have high healthcare utilization and visit the ER for most of their healthcare and social needs, and again, rendering them vulnerable of contraction or transmission. So the other thing too is to consider what we consider in our conversation around interventions, what it means for those who are housing insecure. So when we say stay at home, what does that mean if a person doesn't have a home? Or if we say socially distance, well, what does it mean when society has always distanced you from you, or you live in a shelter with no access to private quarters, or you are made to isolate with concomitant mental illness, or you're asked to wash hands but there's no access to water. So again, there's a lot of conversation that needs to happen in terms of as we address this. And one of the things that we have done is to collaborate and in an initiative to provide on-site testing at the shelters around Detroit, and create a process of that that is specific to the population. And we're working hand in hand with the City of Detroit's Mayor's Office, Housing Revitalization Department, the Detroit Health Department, and of course with Wayne State University Physicians Group. And truly what it is speaking to is the need for a coordinated, structured strategy through a health equity approach necessary to interrupt the significant impact of homelessness on health throughout those citizens who are overlooked and oftentimes marginalized. So with that, I will hand the floor over to our next panelist as she introduces us to the root causes of that also impact upon vulnerable populations, and specifically African Americans, and speaks to the disparities that community is experiencing to the extent that it is. And so it is my pleasure to introduce Dr. Kamara Jones. I will also introduce the other two panelists, and then they'll go ahead and take it away. And so Dr. Kamara Jones is a highly esteemed colleague of mine. She's a family physician and epidemiologist. Her work focuses on naming, measuring, and addressing the impact of racism on the health and well-being of the nation. She is the 2019-2020 Evelyn Green Davis Fellow at the Radcliffe Institute for Advanced Study at Harvard University, and a past president of the American Public Health Association. Her career includes both teaching at Harvard School of Public Health, Morehouse School of Medicine, and Rollins School of Public Health, and public health practice with the Centers for Disease Control and Prevention. She aims to catalyze a national campaign against racism. I'll also go ahead and introduce Dr. Helen Muguni, who is an associate professor in the Department of Infectious Disease and Global Health at School of Veterinary Medicine at Tufts University. She works at the cutting edge of the One Health initiative that combines a multidisciplinary approach and human, animal, and environmental health knowledge for monitoring and prevention of current and emerging infectious diseases. She served for the last 8 years as the Tufts Senior Technical Lead of the USAID Emerging Pandemics Threat 2 One Health Workforce Project. And in this position, she coordinated projects across 8 African nations: Kenya, Uganda, Tanzania, Rwanda, Ethiopia, Democratic Republic of Congo, Senegal, and Cameroon, and covered 26 institutions of public health, environmental sciences, and veterinary medicine. She also provided technical support in infectious disease training, gender, ecosystem health training, and One Health curriculum integration. And finally, my pleasure to introduce Dr. Stephanie Hartwell, a renowned sociologist. She conducts both large and small scale research and evaluation projects focusing on transitions from institutions to the community, with emphasis on vulnerable populations, including formerly incarcerated persons released from corrections and victims of gun violence with mental health and substance abuse issues. She is currently the Dean of Wayne State University College of Liberal Arts and Sciences and is a recipient of the Chancellor's Medal for Distinguished Teaching. So I would like to hand over the floor to Dr. Kamara Jones to talk to us about the root causes of these disparities as it relates to structural racism.
So I'd like to share my screen, and I'm very appreciative of this opportunity to be part of this amazing assemblage. I've already learned so much. And in the few minutes that I have, I want to talk about the importance of naming racism again, and still in the midst of this pandemic. So we know that as of December 2019, there were no humans on this planet that were immune to the coronavirus, the SARS-CoV-2. And we would expect that if opportunity were equally distributed across the planet, or at least in a given nation, and if exposure to risk were equally distributed, then there would be no way that we could slice and dice the population and find differences in the infection rates, hospitalization rates, or death rates. But all of a sudden, we're waking up when, starting with Milwaukee County, when data started being presented that highlighted the extreme excess risk for Black populations in terms of infection, hospitalization, and death, with at each state, the risk kind of amplifying. And so all of a sudden, people were mystified. And I have to just say that all it was evidence that we do not have a society in which opportunity and exposure, resources and risk are evenly distributed by race. In fact, there's the name for the system that structures opportunity and assigns value in our country, and that is racism. So all of a sudden, I and many others are talking about racism as a root cause of the excess COVID-19 Black deaths, just as they're a root cause of the excess numbers of our babies, Black babies dying before their first birthday, or mothers dying in terms of pregnancy-related deaths, or people dying from heart disease and stroke and the like. This is an opportunity, though, because the Black excess deaths are piling up so fast and so unexpectedly that they can't be normalized, they can't be ignored. For us to name racism right now, to wake this country up again from its racism denial. We woke up after Hurricane Katrina, when the levees broke and it was all of the Black folks on the roofs. We woke up when the Flint water supply was poisoned. We wake up, when 9 people were massacred in Charleston at Mother Emanuel AME Church. We wake up every now and then and say, oh, maybe there's racism in this country. And then we fall back into what I call the slumber or somnolence of racism denial. So I want to just give you some tools right now, very quickly, 2 tools. One is a story and one is a definition that will enable us to continue when this is all past us in 18 months and 2 years, or maybe never, who knows. But when this is past us and people are seduced into going into racism denial again, I would like us to have the tools to keep racism on the agenda so that we can continue to name racism identify how is racism operating here, looking at the mechanisms so that we can intervene on them, and then organize and strategize to act. The first of these tools is a story, and Ijeoma asked me to tell this story. At first I was just going to talk and kind of do some other framing, but this is a really important thing for us to do, because this story, if I have just a few minutes to talk to people about racism and to show them that yes, racism exists and this is how it operates, this is the story, based on my own real life experience when I was a medical student. So as a first-year medical student, of course, I was very studious. So one Saturday, weekend day, but I'm studying long and hard in my apartment, and then some other friends come over and we all get to studying long and hard, and it gets late and we get hungry, and I have no food in the apartment, which was typical of me. So my friends understood. So they were like, okay, Kamara, never mind. Let's go into town and find something to eat. So we go into town and we find a restaurant, and we walk in and we sit down, and the menus are presented, and we order our food, and the food is served. And it's a remarkable story yet, although it's remarkable in these days because it's dangerous for us to do this now, but that's not the point of this story. So far, most of us have had this kind of experience. Nothing to learn here yet about racism, but as I sat there eating with my friends, I looked across the room and I noticed a sign, and that sign was a startling revelation to me about racism. So now I've intrigued you, and you're like, Dr. Jones, what did the sign say? What did the sign say? The sign said open. So now I may have lost many of you. So let me recap. Here we are sitting in a restaurant eating. I look across the room. I see a sign that says open. And if I hadn't thought anything more about it, I would have assumed that other hungry people could walk in, sit down, order their food, and eat. But because I knew something about the two-sided nature of those signs, I recognized that now, because of the hour, the restaurant was indeed closed, and that other hungry people just a few feet away from me, but on the other side of the sign, would not be able to come in, sit down, order their food, and eat. And that's when I understood how racism structures open, closed signs in our society. That racism structures, if you will, a dual reality. And for those who are sitting inside the restaurant at the table of opportunity eating, and they look up and they see a sign that says open, they don't even recognize that there's a two-sided sign going on, because it is difficult for any of us to recognize a system of inequity that privileges us. It's difficult for men to recognize male privilege and sexism. It's difficult for white Americans to recognize white privilege and racism. It's difficult for all Americans to recognize our American privilege in the global context in most times. Yet those on the outside are very well aware that there's a two-sided sign going on, because it proclaims closed to them, but they can look through the window and see people inside eating. So back inside the restaurant, to those who ask, is there really a two-sided sign? Does racism really exist? I say, I know it's hard for you to know when you only see open. In fact, that's part of your privilege, not to have to know. But once you do know, you can choose to act. So it's not a scary thing to name racism. It's actually an empowering thing. It doesn't even compel you to act, but it does equip you to act, so that if you care about those on the other side of the sign, which is an if, but if you do, you could even talk to the restaurant owner, who is, after all, inside with you. And you could say, restaurant owner, there are hungry people outside. Why don't you open the door again? Let them come in. You will make more money. And oh, the conversations we could have. Or maybe what you'll do is pass through food through the window. Or maybe you'll try to tear down that sign or break through that door. But at least what you won't be doing is sitting back saying, wonder why those people don't just come on in and sit down and eat, because you'll understand something about the two-sided nature of that sign. So when I have a chance to talk to people very briefly about racism, I give them this story to communicate that yes, racism exists in this country, and it is structuring two-sided or multi-sided signs in our society. And further, I often challenge people with the question, how could people who are born inside the restaurant know something about the two-sided nature of the sign? Because in fact, there are many, many ways to know. I have started 3-hour conversations with that one question. So we won't go there now, but I encourage you to think about that and talk about it with your colleagues and family members and whoever else, people that you are on chat with as we go forward. Just 2 other things I want to do, 2 definitions. My definition of racism very quickly, and then a definition of health equity very quickly, and then I want to learn from what the others are saying. When I say the word racism, I'm clear I'm talking about a system, not an individual character flaw, not a personal moral failing, not even a psychiatric illness, as some people have suggested, but a system of power that does two things. It's a system of structuring opportunity and assigning value, structuring opportunity and assigning value. And on what basis is the opportunity structured? And on what basis is the value assigned? That's on so-called race, which is the social interpretation of how one looks in our race-conscious society. And this system has three impacts. It unfairly disadvantages some individuals and communities, which when we do talk about racism at all in this country, that's where we go. But every unfair disadvantage has its reciprocal unfair advantage. So racism is also unfairly advantaging other individuals and communities. That's the whole issue of unearned white privilege that we hardly ever talk about, because it makes some people, especially some white people, uncomfortable. And I actually encourage now my white colleagues, if you feel uncomfortable, I used to say, shake it off, stay with me, I'll tell you more stories. But now I say lean in, because I've come to recognize that for all of us, the edge of our comfort is our growing edge. But the third impact is one that's often overlooked in our society, and that's how racism is sapping the strength of the whole society through the waste of human resources. And I'd be happy to go deep on any of these areas in a minute. Just to close with a definition also of health equity, which has a three-part definition. What is it? How do we get there? And how is it related to health disparities? Where I define health equity as assurance of the conditions for optimal health for all people. I define health equity as a process assurance, not an outcome attainment. Assurance of what? Of the conditions for optimal health, which are the social determinants of health. For whom? For all people. That's what makes it equity. How do we get there? Achieving health equity requires at least these three things: valuing all individuals and populations equally, recognizing and rectifying historical injustices, and providing resources according to need. And finally, how is health equity related to health disparities? Health disparities will be eliminated when health equity is achieved. And I actually just published an op-ed in Newsweek 2 weeks ago, where I took those three principles for achieving health equity and applied them to the COVID-19 challenge that we're living right now, as well as suggested them as a basis for building a new future going forward, because we cannot afford to return to the old status quo. Over to our next speaker. Can't hear you. You're muted. You're muted.
Oh, thank you so much. Yes. Thank you so much, Dr. Jones. We need a hot minute to just drink some water and process. That was amazing. Thank you so much. I hope to get that link to your op-ed from you afterwards. I will also make available to the audience your link, your CNN interview, where you beautifully articulated some of these ideas and applying it to the challenge of COVID-19 pandemic. And I'm excited for the questions that are forthcoming as a result of this amazing rendition you have proffered to us this afternoon. So let's move on to hear from Dr. Amaguni. And she has a unique perspective to share that I believe people rarely, those of us of the human biomedical background, rarely hear. So Dr. Amaguni, take it away, ma'am.
Thank you so much. Thank you, Dr. Kamara Jones, for that wonderful presentation. It's amazing just how much we learn from listening to others. And thank you so much, Dr. Opara, for this invitation. I'm going to talk a little bit about One Health, Africa, and gender as well. I don't know if that's mine or where the noise is. Can you hear background noise, or is it only me?
There is some noise. Let me see if I can make sure. Please, everyone, make sure you're muted.
Tomorrow? Oh,
okay.
Oh, okay, okay. There we go. Thank you. And so I'm Helen Amuguni, and I'm a veterinarian. So thank you for that opportunity to speak among, I'm sure, human health professionals. But I'm hoping that there's some veterinarians listening as well, and environmental scientists as well. And I work at the One Health intersection. I've worked for the last 10 years with USAID project on emerging pandemic threats, focused on Africa. And I sort of want to start with talking about One Health, because that's the big reason we are where we are right now. We are talking about COVID-19, and we think about where did it come from and how did it get here? And I hear a lot of people saying, we are surprised that it happened. I can tell you that it's not a surprise that it happened. We've been expecting something like this, and it's been happening on small basis over a long period of time. This picture is an image of Wuhan, the wet market, where it supposedly started. And this virus is supposed to have jumped from bats to maybe another live domestic animal into humans. That's really common. It happens a lot. And because as humans right now, we are really closely linked with animals. At this market, they were selling civets, they were selling dogs, they're selling porcupines, all kinds of animals, and then there's vegetables. So it's a pot. It's really a cooking pot where everything is happening. And we know basically that that's usually what leads to viruses jumping from other species of animals to humans, and vice versa, by the way. It happens also in the other direction. This is an image of China, March 31st, reopening these markets. And today, as I was coming to this, on TV, there was a story about the US government talking to the Chinese government about wildlife trade. And a lot of these things are so interrelated. They drive infectious disease emergence. Globalization and travel, the way we are traveling around the world, our interaction with wildlife, environmental destruction, climate change, environmental pollution. It's very nice to see the different, when they show on TV, the different countries and how all of a sudden the air is clean because we are all sitting in our houses and not doing much. But those are really the impacts why we are in this position right now. And what we need to do, I just wanted to put up this. Every year, there are 5 new human diseases that emerge every year. And 3 of those are of animal origin. 75% of emerging human diseases are of and have an animal origin. 60% of human infectious disease are zoonotic. That means they can be transmitted between humans and animals and vice versa. And 80% of potential bioterrorist agents are zoonotic in origin. And so that's why we talk about One Health. We say, you can't wait for patients to show up in the emergency room. Then it's too late. But if we can think back and bring together different disciplines, working together, human, animal, environmental people, and begin to plan out and prepare in advance, then we can be prepared for this. And we've been talking about this for a really long time. What can veterinarians do? What can social scientists do? What can anthropologists do? What's the role of an engineer when there's a cholera outbreak, you know? And so all these different disciplines have a role to play and to be engaged to plan together from the beginning so that we don't wait to respond when there's an emergency. We prepare in advance and we know what role each one can do. If we understand the emergence of diseases from animals, then veterinarians, wildlife scientists, you know, all those people, environmental people can work together. If we understand that as we are cutting down the palm trees, we are therefore removing monkeys from their habitat, and those monkeys are moving into human environments, and now malaria is becoming a zoonotic disease in Indonesia and Malaysia, then we begin to think about why are we cutting down forests and creating this kind of environment. And so I wanted to start with that and just mention about One Health. It's this collaborative effort of different disciplines working locally, nationally, and globally to attain optimal health for humans, animals, and environment. It's one of the good frameworks that we can use to strengthen health service delivery. And I think it's a good way to start working together, bringing together all different disciplines. We are so used to working in our silos. You know, we're so used, you're a medical doctor, you just do your medicine. You're a vet, you just do you're a social scientist, you just do your social science, you know. But right now we are being given this opportunity to actually take a step back and think, how do we engage each other? I want to pivot a little bit to talk about Africa and to actually say that the countries I was working in are actually displaying this One Health approach. They're sort of really using it. This is the map that you see, the Johns Hopkins map that shows the coronavirus. This is from yesterday. It took this yesterday. And I want you to take a look at all the different countries around Africa, and then to see how many cases so far are showing up in Africa. I can tell you that the East African countries that I work in and I've worked with over a long period of time, those are Kenya, Uganda, Rwanda, Tanzania. I will talk a little bit about those. I don't want to blow the trumpet too much at this time because we never know what's going to happen in the future. But I wanted to share some of the best practices and what they've done as a part of this to respond to this outbreak. And all these countries have what they call a One Health platform, a One Health framework, a One Health task force. I think also based on the fact that a lot of these countries have experienced many outbreaks in the past, there's been Ebola, there's been Marburg, there's been, you know, measles, they've all been these outbreaks. So I think they were a bit more prepared to respond to this kind of pandemic than many other countries. And so starting from March, Kenya, Uganda, and Rwanda also their first case in March. And starting the moment the first case appeared in Rwanda and Kenya, within Rwanda, one of the first things that Rwanda did was actually put washing stations in the city, everywhere in the city of Kigali. They went through the same procedure with the first patient. That was with the first person who showed up in the country with one. You know, the moment one person showed up, they went into this response mode. And I think one of the basic reasons they did this was because the healthcare systems are weak. And so there was that thinking of, if we let this overwhelm our healthcare systems, we're gonna lose so many people, you know, and that's been the story. What will happen to Africa when this hits Africa and this overwhelms Africa? I can tell you that East Africa jumped on it right away. Kenya, working together, and it was not an individual, it was a regional response, working with the Africa CDC, with WHO, within the month of January and February, WHO and Africa CDC were training immigration officers to be able to identify these diseases. They were training heads of hospitals to be able to know how to deal with the virus. They were training district people in charge, like administrators, to know how to respond to these when it came to their district. They were training laboratorians to be able to test and to trace and to track the infections. And so they started off, the CDC started off, the Africa CDC started off with 12 countries. It identified 12 countries that were directly linked to China and say, this country has so many flights coming in from China, we're gonna start by training that. And then they expanded to about 42 countries to be able to train people. And then the countries also stepped up and put in place mitigation, containment efforts. Masks, wearing masks, just what we're doing right now, wearing masks, social distancing. Some of these cannot be done very effectively, but there's some things like, for example, in Kenya, there's so many locally made masks that a mask is costing like 5 shillings, like 20 cents. So everyone can afford a mask. And if you're caught not wearing a mask, you pay $5. So they're putting that on you. They're saying masks are available and you can actually make them locally in your house or use a cloth. And so if you're caught not doing it, you're gonna pay for it. At the same time, like I said, washing stations were everywhere. This is an example of a task force that was created in Rwanda 2 days after they got the first case. They created this task force that does contact tracing and tracks everyone. And what happened is, if anyone arrived at the airport, first of all, they banned flights. Flights were closed. There's a period where flights were still allowed, but if you came from any country, you are gonna be quarantined. And what they said is, we cannot afford to keep people in quarantine. So if you decide to come to Kenya, Uganda, or Rwanda, we are going to quarantine you at your expense. We're going to quarantine you. They identified fancy, nice hotels, and they told those hotels, we will use you for quarantine. People will come and stay there, but they will pay for it, you know? And so that was easy on the government, especially for foreigners, except for locals who are not, you're supposed to quarantine in your own house. But what Rwanda did is started this contact tracing and tracking. Amount of testing, like we talk about testing in this country and we think, you know what, we need to do a lot of testing. They recognized that they could not do that. They could not do massive testing. And so they really, really focused on tracking, identifying whoever is positive, and then contact tracing that person, and then isolating. And so that has happened across the 3 different countries. I did want to show you a sample of a mask that's locally made, made from banana leaves. Those masks are made from that. But the contact tracing and isolation has really been important because they can't be able to sample everyone and test everyone. And so they've been able to contain it. I think right now, Kenya has the highest number of cases in the region, and that's 303 cases as of this morning, with 14 dead people. Rwanda has 150 cases, no one has died. Uganda has 58, no one has died. And this might end up blowing out of proportion, but it's been a month since the first case showed up in these countries. And they've really, really been on top of it, trying to respond to that. I do want to move on to just talk a little bit about gender in the next few minutes, because we can't forget to talk about that. The story that's coming out is how there's such a discrepancy between who is dying of COVID in the different countries. The same number of people, both men and women, are affected equally, as this chart shows, in about 47% female, 53% male. But when it comes to death, this is what you see. This is what we've seen in Europe. This is what we've seen in South America. And this is what's beginning to be recognized here in the US. You can see that 72% in Finland of people who died were male, and only 28% women died. And so as this is becoming really clear across all the different countries, as this is becoming really clear, people are beginning to analyze, is it biological? Is it social? In other words, is it sex or is it gender? I think that's one of the factors that we're beginning to think about. So men are affected. A lot of older men are dying from 60 years to 90 years old. If you see the statistics, it's a lot more men who are dying. But as we think about it, and from what Dr. Jones was even talking about and Dr. Opara, that's not the end of it. The end point is even the impact. As you begin to look at the impact of COVID-19, we can focus on the fact that men are dying right now. And maybe they've said some of the reasons are immunological. The immune system of men is somehow responding differently to this virus than it is in women. This was seen with MERS, and this was seen with SARS as well. But if we look at the impact, we can also begin to look at the gender-based impact of this virus as well. And just generally, both within Africa and even here in the US, we can see gender disparity. One of the things that we're talking about is just even basic things like personal protective equipment. Did you know that PPE is actually generally built for men and not for women? And so a lot of all this PPE that's being trained around, like masks, is actually made for men. Are we sure it fits? And it fits well? So thinking about that, these stay-at-home policies have ended up increasing workloads. Workloads for who? This morning I had a meeting, and like Dr. Opara, I had 3 of my colleagues who had children, and they were running around in the background, and the ladies were trying to multitask most of the time. They were the ones doing it and teaching, and it's coming out that it's really affecting a lot of women, and the workload has increased. Maybe it has increased for men. Talking about health disparity, healthcare workers, a lot of the healthcare workers, many of them are women. A lot of the low income, essential personnel who are working in stores and working in all these certified nursing aides in a lot of these institutions, many of them are female. And so thinking about that from a gender perspective is really, really important. One of my colleagues told me this morning that she, because she's working from home, she has no uninterrupted time. Like she really doesn't have time to even sit down, and because her 7-year-old is with her throughout. So she doesn't have that time right now. And we've talked a lot about increased gender-based violence. There's a study that came out that says, we talk about stay informed. One of the ways to keep people from not getting COVID-19 is to stay informed. But 393 million women, mostly in Asia and sub-Saharan Africa, cannot afford a phone or are illiterate. And so how will they stay informed? We talked about in Kenya and Uganda and Rwanda, the way they're sharing this information is through WhatsApp. And with WhatsApp, you have to have internet, you have to have this, that kind of thing. So that's one of the reasons. And so I wanted to give another example that in Uganda, with the policies that have been put in place, however good, those stay-at-home and quarantine policies, women are not able to get into hospital to deliver. I read a report yesterday that 7 women died just trying to get into the hospital to have a baby. And also a lot of countries are not disaggregating information by sex, so we don't really know what's happening. I present this as areas for further examination, just a little light into that, and areas for further examination, but I'm going to stop there. Thank you.
Thank you, Dr. Muguni. Just a lot of food for thought in the terms of how gender works as in the conversation and the narrative around the disparities and inequities exploited by COVID-19. I know you didn't touch on this yet, but a lot of work has been done. We're hearing a lot of reports about increase in gender-based violence during a time such as this. So that would be something else for the audience to consider as well as we go forward. But thank you so much for really shedding a light on One Health and the necessity of a collaborative, interdisciplinary effort as we really just approach everything, and so that, as Dr. Jones said, we don't go back to normal, but that we move forward to a better iteration of what it means to be people in this world. I want to quickly pivot to Dr. Hartwell. I want to remind the audience that this event is scheduled till 1:30. So, but however, of course, you're very welcome to leave to other things. I know how busy we've become during this time, but we do have up to 1:30. But I want to pivot to Dr. Hartwell very quickly, and I will share my screen for her slide.
Hey, Juma, this is Tina. Sorry, I have a quick comment on the presentation. I just joined. This is Tina Chopra. And again, thank you for the wonderful presentation. I was really intrigued by the comment on PPE and how it is made only for men. And I have been, as an infectious disease physician and a hospital epidemiologist, this is a major obstacle we faced in the midst of the crisis when we were getting more PPE in the form of from federal or state or from any kind of resources. This is so true, and it can have major implications as far as exposures are concerned. So definitely there is more data that we are mining and trying to understand this, but question is, were more exposures happening in our women colleagues than in our men colleagues?
Dr. Chopra, thank you so much for that question. With your permission, I would like to table that question to after we hear from our last speaker, also because she has to leave early, and then we can take time and totally open it up to the audience Q&A. We'll start with your question, if that's okay. Thank you so much.
Thank you. Thank you.
Just a few minutes with Dr. Hartwell. Dr. Hartwell, please take it away.
Yeah, sorry about this. I have an emergency 1 o'clock meeting, but it's supposedly the 1 o'clock meeting is going to be 15 minutes. So I'll probably try to zoom back in because this has been fascinating, Ajima. Thank you for having me. I love the other two speakers, very inspirational. I just wanted to start, I'm going to sort of buzz through this and then hopefully be back for questions. But just to start with a quick story, we did lose a Wayne State student/employee from my college He was a janitor and also a sociology major, and he was over 100 credits, so we're going to be able to give him a posthumous degree, but he was an African-American man who died of COVID. And what's interesting about his story is it's such the razor's edge story, right? Because the first people back to work are the folks that are doing the cleaning. And so we're rushing around now at the university trying to find PPE so the folks in facilities can get into the buildings to clean for reopening. And of course, that's the whole janitorial staff. In those kind of positions, those kind of service sector jobs are often disproportionately held by folks that are trying to get their education, that are trying to, make their way in the world. And in some ways, if Darren didn't have his janitorial job at Wayne State and didn't go to school at Wayne State, what would be his other options? And so I work in urban areas, and I work with populations in transition, folks with substance abuse issues, mental health issues, folks transitioning in and out of jails involved with the criminal justice system, and then prisons too, of course. So just in thinking about COVID, prisons, you're sentenced, that you're there. They're not going to give you an early release because of a pandemic. So prisons are managing folks that are positive with COVID by managing number of guests and visitors into the facility, and then quarantining off folks that are positive. But again, prisons only have so much structural space. So you think about a university closing down because of the population coming in and out, but prisons have limited space. So they need to think creatively about where they're going to quarantine individuals and how they're going to deal with that. But jails are far more porous. So you're probably all reading a bit about folks coming in and out of jails, and now they're doing early releases and diversion. So folks that otherwise would spend time in jail if they don't have money to post bail are being sent back to the community. Ajima knows we've been talking about doing a bit of an op-ed about talking about what happens to people that are so disorganized that they end up at the criminal justice system, but then are turned away at the doors and have no place to go. Or what kind of, I know in Connecticut, they won't release you early from jail unless you have a safe place to go. But how do you assess what a safe place is? And what kind of environment are you returning to? I do a lot of work in Detroit and was looking at some data just today in some of the neighborhoods. And one of the neighborhoods we're looking at has lost over 50% of the population since 2009, and 30 to 40% of the homes don't have running water, but that's habitated and unhabitated homes, and 40% don't have working kitchens, which of course is related to the water. But then you think about food and nutrition and access to those things, and social distancing and being able to quarantine. So there's, limitations in that for folks with unstable housing, as Ajima said, but some of these places that folks that are interacting with the jail and the criminal justice system end up back in. And then the final thing I wanted to just mention, in a population to keep in mind, is folks with major mental illness, because healthcare has turned on its edge where everybody's pivoted towards COVID, but things like mobile outreach teams, support groups, they're not meeting in person anymore. And so if you have a major mental illness or an illness that you need to sort of figure out how to organize your life around, and you go to support groups and you go to clubhouse support, and you can't do those things anymore, how destabilizing that can be for you. So managing through telehealth, while it has some promise for well populations, certainly has its limitations. I know that folks that work with people with mental illness are using the phone quite a bit, but it's not the same social connection. And then understanding of social distance also changes. So when you're looking at populations in jails and prisons, and you have to think about the air quality and how far apart people stay. Ajima works in shelters, the beds are 5 feet away, from each other. How do you get them 6 feet away when you have 100 people in a shelter? So I guess that's all I had to say, that we really need to think more about what we did routinely and be able to plan a little bit more for these kind of disasters related to environmental justice issues and related to pandemics for vulnerable populations. And oftentimes we're working at a level of chaos with these populations. Like, you're always sort of managing crisis with these populations. So then when you're thrown into a much larger crisis, you don't have that ability to plan. So we're going to divert people from jail, but then what? Where are they going to go? What is the outcome of that going to be? And to start to think more about that. And I'm just gonna, I'm sorry I had to rush through that, but I'm gonna just hop off But if you could grab the questions, Ajima, for me, and I'll try to call, hopefully I'll be done at 1:15 and I can hop back on.
That'll be perfect. Thank you,
All
and
right,
I
thank you
appreciate
so
your
much.
time. Thank you. And so to everyone, thank you for staying so far, and thank you to our panelists, Dr. Jones, Dr. Hartwell, who will be jumping off and jumping back on shortly, Dr. Amuguni. I'm absolutely gonna forego my piece. I have so many questions, but guess what? I can call them later tonight, and we can drink tea, or wine, and talk more. But for you all, it's more important that to get your questions in. So I want to start with Dr. Chopra's question, and then there was another question on the chat as well. So we'll start with those two questions. And Dr. Chopra's question was about PPEs and knowing the disparity in the PPE shape. Are we seeing any disparity in exposure linked to that? And then, and if you can kind of share on that, Dr. Amuguni. And also with that, as you answered that, if you could just share one or two words on the gender-based violence uptick that we're seeing as well during the pandemic.
I will unmute. I do want, maybe I'll start with the gender-based violence. One of the things we are seeing is we're actually seeing in the US, for example, a reduction in gender-based violence reports. And there is an assumption that people are unable to report that because now people are stuck at home with their abusers, be they male, be female or children. And so there is the number of cases, gender-based violence or domestic violence cases being reported are much, much lower. And one of the things that some organizations have done is actually start working with like food stores to enable food stores like Rice Now. There's an organization called Rice Now to enable food stores to be a safe place for someone. And there's a particular word you can say if you're going at the if you're at the counter and you're going through gender violence at home, you can tell the counter person that word and they will immediately call someone for you. They will immediately give you a way to get out of that. So they're being trained to be responsive to that. So it's becoming really, really innovative, but we see that happening. And so that's just to mention a little. To talk about PPE, this is a new thing that no one had thought about. And it's sort of the same with gender issues. We talk about diseases. A lot of diseases or research is mostly done mainly on males. And then you assume that those diseases affect women equally, or something like that, testing cases, things like that. The assumption is that it affects women or women will have the same sort of response to that. And so this is an area that we've talked about for the last 20 years. And then an emergency like this, like Dr. Jones was talking about, an emergency like this comes up, then we wake up again and we're like, oh, this is an issue. Let's think about this, and then we go back to sleep and wake up again 5 years later when there's a different issue. So being able to even just provide sex disaggregated data, how many nurses have died and how many of those nurses who have died are women? That kind of information, that's powerful information that allows people to begin to think about it. But a lot of governments now are not thinking about, they're just thinking people are dying. A lot of people are dying, therefore we just report people who are dying, So in that sense, it's really something to activate against, to say, you need to provide us with this data and we need to think through how to develop that. I always say, and allow me to make this one more comment, I always say that if men were to get mammograms, there would be a different mammogram machine right now. It would not be that painful machine that is still being used, because it would have been, and something would have evolved and it would have changed somehow to a different kind of machine that's maybe just an injection, or you just get your blood drawn and they can see if you have cells for cancer in your breast. So yeah, that's just my personal opinion.
Duly noted, Dr.
Yes.
Amuguni.
Yeah.
Dr. Jones, I want to level. We have a question from Raven Batshon. I want to level this question to you. I think this will be really great and really segue us to speaking about bringing, and you did an excellent, wonderful job of providing the framework. And then as we connect the framework to the day-to-day, this I think is a great question. So she's really asking about the CDC's recommendations and the fact that those recommendations are difficult to apply to everyone, that recommendations are not equitable. They did not take into consideration the different contexts that people live throughout the country, especially the context in communities of color and African Americans. And so she asked a question, what are some ways we can apply a lens of critical consciousness to redefine these guidelines in order to then make them applicable? I think it's a powerful question to really translate our understanding of the structural systemic racism threaded throughout this nation and has still not been unthreaded, and how it then manifests through guidelines and recommendations and proposals
Yes.
and policies
Yes.
that are not considered. And so how do we apply a lens of health equity and critical consciousness to redefine and reapply these guidelines for all populations?
So I think I'll start answering that question by observing that the way, so I described racism, but I didn't talk about the way that it's manifesting in these Black and brown excess deaths. And so it's manifesting by increased infection because we are more exposed and less protected. So we'll go back to that. And then once we're infected, because we carry the burden of increased illness because of the conditions of our lives, living in communities that have been underinvested, poisoned, no green space, no food, all of the things that have been described before, then we carry these chronic diseases. And so once infected, we are having more acute manifestations. So let me take each of those in turn. And healthcare has a tiny little bit to do with it, but it's not, the main story is, why are we in more of the frontline jobs? So the analysis says it's because we live in racially segregated communities that are then educationally segregated, poor job options, all of that. Or we just don't have the accumulated wealth because of the history of building wealth for others and not being able to accumulate it for ourselves and all of that. So what we need to do on that kind of exposure side, we're also more exposed because we're more likely to be unhoused or more likely to be incarcerated. We need to make it more feasible for more of us to safely shelter in place. What do I mean more feasible? Well, the CARES Act, the third rescue package that Congress passed a few weeks ago and that was signed a few weeks ago, still people haven't gotten those one-time payments, but a one-time payment is not going to do it for the duration of what this is going to be, because what we're really doing is we're waiting for a vaccine or a cure, and that's going to be 12 months to 18 months, right? It's not going to be like one peak and then down. It's going to be lots of peaks, and depending on how we manage things, it can be lots of little peaks or big peaks. But anyway, so we need to make it more feasible for people to safely shelter in place, which means making it more financially feasible for those people who are going into work because they have to, or else they can't eat and can't pay their rent. We need to make it, especially with the Southern governors. Now, many of the Southern governors threatening to reopen the state, that we have to make it possible for workers, especially in these right-to-work states where they don't have union protection, to say, no, I am not going to trade my life for a paycheck, right? So we need to have strong protections for people who, until the public health people say that it's safe, that they can stay home from work and get unemployment insurance or paid sick leave, all of those things, that the protections that are supposed to be there that haven't really been accessed fully by our communities. We have to make that more feasible. For the people who are on the front lines, cleaning the hospitals, driving the buses, picking up the trash, delivering the food, staffing the grocery stores, they need to have full PPE, right? Because we're more infected because we're more exposed and less protected. So we have to deal with the protection piece of it. They have to be recognized as being a core part of the essential workforce and get the N95 mask, not just a little cloth mask, and not, as some people in some factories have had to use hair nets as a mask. So we have to address the protection issue and also give all of our essential workforce, from the people who are doing sanitation and driving and warehouses and farm to the doctors and nurses, hazard pay. So those things are about more exposed, less protected infection. So we're going to deal with that. Then once people are infected, we know the communities that already have more health vulnerable people because of the conditions of our lives and the living on the closed sign of the society and not having the full healthful resources. So if we know that those people are going to be more infected, we need to put more healthcare resources in those communities. We need to make sure that in a city that no hospital is in the position of having to ration ventilators or emergency dialysis or anything until all hospitals in the city are doing that. That is, there should not be one hospital with insufficient numbers of ventilators per patient and five miles away there's another hospital that still has openings. That should not happen. We need to be very careful. We need to have community input on what is being described as crisis standards of care. So this is like when the thing gets so bad that the usual patient physician relationship breaks down, and already the families can't be there and all, but when you start rationing resources, we have to make sure that people are not penalized for having diabetes or heart disease or the like. And I've actually, maybe in a very provocative way, suggested, and then a colleague of mine, Dr. Michelle Holmes, has actually developed on change.org a petition calling for lotteries to be used in the random allocation of scarce resources. Because how can we differentially value different people's lives, really? How can we do that without bias or without using the proxy of expected 3-month survival or expected 12-month survival? That's a proxy for the other conditions of your lives, which is baked in, where racism is baked in. So we have to do that. And then the last story on this, on the immediate response, as guided by a kind of a racism structural analysis, is that to the extent that we can start treating this as in East Africa, the East African countries that Dr. Amaguni talked about, where the crisis was treated as a public health crisis because they knew they could not afford to let it become a medical care crisis. In this country, it looked like the CDC was muzzled or threw up their hands or just gave up or whatever. So we have a medical care crisis in this country because we did not do the public health stuff that we need to do, which includes population-based surveillance on, on probability samples of populations in a given area, oversampling where we already know now that we're overrepresented in terms of communities of color, poor communities, jails and prisons, nursing homes and other senior centers. But we need to have a good handle on how much infection is there today in this community. So we have to be testing asymptomatic people too. The picture that we get from doing the antigen test will help us predict where we need to have our healthcare resources in 2 weeks. The picture we have now about diagnoses made at the hospital, that's a 2-week-old picture. Mm-hmm. That's the tip of the iceberg from something that happened 2 weeks ago. It doesn't tell us anything about what's happening today. Mm-hmm. If we do the population-based thing, this is my last point, and I'm rounding the corner here. But if we do the population-based testing, including of asymptomatic people, then when we first of all, we'll know how to allocate resources. But then when we identify asymptomatic people who are infected, we ask them to isolate. So we're already interrupting the spread. We're already intervening, altering the course of the pandemic as opposed to just documenting the course. And then, of course, we do their contact tracing, and then we isolate those people even before they've manifested anything, but especially then if they become infected. That's 2 generations of intervention to change the course. When we do that, it will change things for everybody. And those of us who have been the canary in the mine, we still might be at the edge of, the leading edge of the impact of this, but it will improve things for us as well.
Thank you, Dr. Jones. Absolutely. I was on a call yesterday, 2 different meetings. I'm pretty much saying the same thing, really bemoaning the fact that the U.S. is grossly under-testing. And
the strategy is wrong. We're under-testing number-wise, but the strategy is wrong. Even if we had all the tests in the world, but we only were testing people with symptoms, then we would be missing the boat. What we are doing is a medical care, narrow, individual focused approach to testing, as opposed to a population-based public health surveillance approach to testing. And everybody at CDC who's an epidemiologist or public health worker knows to do this. So I do not know what happened in this country.
It's neither do I. I do want to applaud the mayor's office, the city of Detroit's mayor's office. At least from a housing insecure standpoint, we have been doing housing insecure population-based testing. That happened. That was really successful and really transformed our overall strategy for those, at least the housing insecure in shelters. Of course, we haven't captured people on the streets and people, the other subgroups within that group, but at least it's a start. But it's a representation of what you're talking about, Dr. Jones. Yes, absolutely needs to be scaled up nationally. Absolutely. Thank you for that.
This is Tina. Sorry.
Oh, and may I just say, Dr. Chopra is our infectious disease guru for the entire city at this point. So yes, Dr. Chopra, go ahead and say and add to the conversation.
First of all, I really applaud all of you. This is an amazing group. And Dr. Jones, I just was so amazed at your comments, which are very clinical oriented, and things that I'm seeing here in the midst of the pandemic and what we have seen in the last 4 weeks. You have reflected a lot of things in your conversation, but I do want to point out that yes, there is a lot going on in the city, but definitely our response is very delayed, and the infrastructure of the health system is broken. And the point here, if we are taking this time and discussing and spending a lot of effort and energy, the point is it doesn't happen again. We need to make sure it doesn't. This is not, COVID is not going anywhere. It is going to stay with us until we have the vaccine. And come May, which is not too far, people are opening shops, so to speak, including doing surgeries, and everybody wants to do that to be able to earn the revenue that is lost. And that is going to further cause peaks of COVID. And moving forward in fall, when we are going to see flu, we are again going to notice upticks of COVID coming with flu. And this issue of health disparities and the social determinants of health, which are most glaring in the city of Detroit than anywhere else, is going to pop up again. So the question is, how can we stop it now and be able to be futuristic and intervene at this point? Yes, we've talked about it, but how are we going to intervene and not make this happen again?
I'm going to thank you, Dr. Chopra. Dr. Amaguni, can you take a stab at it? And then Dr. Jones. That's a great question.
Hello. So one of the things I was thinking, allow me to just say something to add to that, to those disparities that Dr. Tina is talking about. One of the things that I was going to mention, and I'm diverting you here a little bit, was one of the disparities that people have not talked about, especially in relation to this COVID, is the fact that everyone has gone home and is doing online, and everyone assumes that online teaching is going, online students are attending class and they're okay. This is a really big disparity with communities of color. Why? Because a lot of them are the essential workers. So I have a colleague who is a professor, and she told me that more than half her class are communities of people of color, and they're not showing up. Why? Because they are double employed now. They are going to the stores, they're working in the stores, they come home, they're so exhausted, they're not able to attend class, but online classes are going on everywhere, So I just wanted to mention that as well as we talk about it. And to come back to Tina, one of the things as we think about COVID-19 and the disparities that exist, and the hospital system. I'm coming from a veterinary perspective, coming from a veterinary perspective, and I think maybe one of the slight differences between veterinarians and human medicine people is that we are population people. We are hard health people. So the epidemiology is always, so the approach is always that way. We think about public health in a sense because that's where we work. We work with humans, but we work with animals and we work with the environment. And so that's always like a first priority to think about. And so if you see the things that have been happening in the system where Dr. Jones is saying, you know what, people are looking at this as a medical care thing and not a public health thing. It is really, really important to take a step back and think of it as a public health thing. And I would want to say that I think this is a challenging point for all medical personnel, especially in the human medicine field, who a lot of the times don't think from that population-based perspective. It's a really challenging opportunity for them to take a step back and begin to think about that. And we've talked about this, like how did we come up with a treatment for AIDS, and how was that able to be provided to other countries as well, especially Africa, where they were the marginalized people. They didn't have any money, they couldn't afford to pay for AIDS drugs. But the activism movement, that movement where we don't give up, we just sort of stand up, and even if you're not counted, you still just stand up and insist on being counted. I think that's really, really important. I don't know if I touched on your question, but that's sort of what I think, yeah.
Oh, no, that's wonderful. You did great, Dr. Amaguni. Absolutely. There does need to be a radical shift in the strategy and the sense. And you're both pretty much saying it as we design interventions to move and a lot of conversation on the chat in terms of what do we need to do for this second wave that is undoubtedly coming. And it truly requires that public health, population-based strategy with this community centered in that strategy, and getting all hands on deck, the animal folks, the environmental folks, the human folks, biomedicine, social sciences, etc. And that's it's so critical. So thank you so much for that. Dr. Jones, you have a little bit to add to that?
Just a little bit, which is, why are people talking about a second wave? Depending on how we act, there's going to be a second and a third and a fourth and maybe a sixth wave. It depends on what we do, and how the amplitude of the waves and the frequency depends on what we do. And what we're waiting is for a vaccine. And then the vaccine has to be adopted worldwide. I mean, it'll be done locally, so maybe eventually it'll be all in the US, but it has to be worldwide. So there's some mystical, magical thinking where people are thinking, oh, we're cresting the peak and we're about to go down. And so now we can open up again. And then people talk about, oh yeah, the second wave in the fall. Oh my God, there might be 2 other waves in between that. So I don't even know why. It seems that people do not understand a few things about this, that there's asymptomatic spread, that the level of immunity right now, we don't even know whether we get conferred immunity once you've come through it, because some people have had 2 bouts with COVID-19. So we actually don't know, even if you have antibody, what titer you need, how durable is that immunity? So we don't know those things. So even the antibody test and the promise of that is wrong. But so it spreads exponentially, especially because of the asymptomatic spread. So people don't have a sense of what asymptomatic spread and exponential spread looks like. Because we don't know the current state, we are always 2 weeks behind in trying to estimate the infection rate, because we're not doing the surveillance, the public health surveillance in communities. We're using test results, which is 1 week, 2 weeks, 3 weeks if it's in the hospital, too late. So there's so many things that we're not doing. And then we have this magical thinking about the second wave in the fall. So what we need to do is put the nation in a medically induced coma, or I was first talking about it as, how there's some rich people who've actually frozen their bodies, like right before they die, they get their bodies frozen because they have some rare disease and they want to be thawed out when there's a cure for that disease. Honestly, we're going to have to think about, how do we freeze the body politic until we either have a vaccine or a cure? That is going to be the way that we save our body politic. If we just decide that we're going to go willy-nilly, then we're going to be dropping off arms and legs and all kinds, and there's going to be the brown arms and the black legs and the poor, and the First Nations people who are going to be the sacrifice people, the sacrificial zones, in that while other people are safely sheltering in place. And when enough of us die, God forbid, so let's say we just went on strike, right? That the essential workforce went on strike, they would know that the food supply is going to be interrupted, that they won't get their meds by mail or anything else. So we have to take it's what everybody's been saying. In a way, we are all in this together because we have always been in this together. I mean, the reality of life is that we are all interdependent, right? Whereas in this country, we have a narrow focus on the individual, which makes us medical, it makes us selfish, makes us all of that. And we need to value all of us, and we need to decide to do something that's going to save all of us.
Absolutely. Absolutely. That was beautifully, I think that is a beautiful place to end today's discussion, if there ever was one. I want to put out three thoughts. There was a great question that we haven't yet gotten to, but I think I'm going to connect this. This is from Ms. Barbara Jones, who is one of our faculty at Wayne State. She teaches peace and conflict studies and does a lot of work community-based, and had a question about community trust, and how that needs to, how do we integrate that issue of mistrust from historical injury, right, and trauma that they have experienced from the nation, and how that is featuring in the COVID pandemic and disparities. And so I want everyone to think about that and have those conversations at home, and we will have some conversations offline. I also want to thank you, Dr. Amoguni, for lifting up digital inequities. Absolutely. Who are we leaving behind as we move forward? What does that mean? Who isn't coming along for progress? And even thinking about vaccine, right? And vaccine, anti-vaxxers, vaccine hesitancy, and how that's going to feature and produce for the disparities, even when we have a vaccine and a cure. So I love that we answered some questions, but we probably generated more. For the audience, I want to let you know that I'm saving your chat questions, and we will try to get those answered offline. We'll be working with the School of Medicine to make sure that this video is going to be available to a lot of people. So many people wanted to call in, and unfortunately we were capped at 100. It appears that we probably had almost double that number of interest. We will do better next time with that. Please fill out your evaluations, and if you're not a resident or student, send me an email, innodim@wayne.edu. It's on the invite for the meeting, and I will send you an evaluation. I thank my panelists, Dr. Jones, Amoguni, and Hartwell. Thank the audience. I wish you a wonderful, safe, and beautiful, peaceful time. And we will keep this going. We're going to have series and episodes coming forward. And I hope that you will also be in attendance. Thank you again so much, and stay safe out there. And I love you. I love you all. Know that.
Thank you, Dr. Opara. This was wonderful. Thank you.
Yes, thank you for the invitation. It was amazing.
I learned so much. Thank you.